Thank you, everybody, for coming to the first installment of ICD-10 Education and Evidence-Based Practice. We are 1/17th of the way towards winning back that part of our compensation. It's free. So I will orient you to the section on neurocognitive disorders in DSM-5, and I will tell you, I am pleased with this section. In this article that I wrote, this was a conference attended by some members of the work group. Dilip Jest was there, and Ron Peterson, and Parminder Sakdev, and the American Neuropsychiatric Association looked at their early work and gave them some feedback on it, and I think either they were thinking exactly the same thing or they listened. But let's jump right into it. So first off is delirium. And what I've done in this slide is I've compared, on the left is the DSM-4 criteria for delirium, and on the right is the DSM-5 criteria. And the difference introduces you to the theme overall of the evolution from DSM-4 to DSM-5. DSM-5 is much more clinically neuropsychiatric. I thought DSM-4 was rather clumsy with this, and DSM-5 I think is a much cleaner, more disciplined neuropsychiatric approach. So you can see that the A criteria have been expanded, and they've added C criteria for an additional disturbance in cognition. And then there are 5 different deliria, and I'm just be glad that we don't have to actually code these things, that they have coders. But I included the proper way to state these. When there's a substance involved, you have to comment first on whether the patient also basically has a drug problem or not, if they've got either a delirium or another neurocognitive disorder from a substance. And there's different degrees of severity of the substance use disorder, and that affects the coding. And I think that in a few minutes you'll appreciate that it's good that we have coders. When it's delirium due to a medical condition, you have to state the medical condition. That comes with its own ICD-10 code that someone else will find. And then you state... Okay, interesting. Again, we'll leave that to the coders, right? When it's due to multiple etiologies, you list each etiology. Oh, you don't have coders. Oh. Some of you may want to be thinking about a career change midstream, coming into the hospital. I wouldn't blame you one bit. Yeah, people code for the hospital. Can't expect hospital docs to know this stuff. Come on.
So, John, are those the actual ICD-10 codes?
These are correct codes. These are examples from the DSM-5. How this would actually end up being stated if you were coding it yourself. But you can see the documentation then calls for, from the documentation you should have some support of the substance use disorders where they exist and the medical problems where they pertain.
Is there an NOS?
There is. It's called unspecified. I think they actually got rid of...
DSM-5 has done away with NOS. It's either other specified or unspecified.
Yeah, exactly. They don't have that NOS terminology. So in this case, you also add these specifiers. 1, if it's acute. 2, if it's persistent. And what I like, we can now talk about different kinds of delirium, hyperactive and hypoactive. which I think will be very helpful on the medical floors, because not everybody that works on a medical floor appreciates hypoactive delirium as delirium. And then mixed level of activity would either be for normal or what you'd think would be a mixed. So you do have to specify on the level of activity with delirium in the DSM-5. And I like this. I think this is useful.
Would that be, I mean, now, first, I'm not sure if I'm going on a limb here. Sundowning, John. So sundowning would perhaps happen with someone who has a delirium, right? And so would that be mixed because they'd be okay, and then the conditions would change and they'd get worse? Is that, am I?
If the A and C criteria for delirium are met, I can't go backwards on this thing for some reason, but that's okay, then you give the diagnosis of delirium. Mm-hmm. But on the criteria were that the condition is not better explained by another neurocognitive disorder, in which case sundowning would be better explained by the dementia. And, you know, from the neuropsychiatrist's perspective, dementia can affect attentional networks in the brain. So you can have like a static delirium from dementia, which can get very confusing if you want to get real detailed with the DSM-4 criteria. A lot of people on P6 all have delirium because their dementia interferes with their attention, and the DSM-4 is a disturbance in attention. So DSM-5, I think, added another cognitive domain and clearly said that it's not better explained by another condition. But it's not so easy with neuropsych. So this is, since you're working on the ambulatory world and you're doing your coding, the fourth digit, the fourth item, okay? The first number after the decimal relates to a 1 is for a mild use disorder, a 2 is for a moderate or severe use disorder, and a 9 is for no use disorder. And each one of these drugs comes with its own little F number that carries through consistently in the DSM. So wherever the drug is causing an intoxication or a delirium or it's a substance of abuse, you'll see like F16 for hallucinogens, F15 for stimulants, F10 for alcohol. You would use the without use disorder for a 17-year-old in the ER who went to a party and somebody spiked the punch with grain alcohol. How's that? Okay. They ate a whole bunch of brownies that turned out to be like a pot brownie or something. Yeah. Something that's neither has ever happened to me. So as Bill said, this is the other specified delirium. And in this case, they're delirious, but they don't meet criteria for delirium. I'm going to let you all figure that out. Like an attenuated delirium syndrome is the specific example given. So if you've got a mild confusional state that isn't quite at the level of delirium, you can call it an other specified delirium. And you have to say what it is. So you could say attenuated delirium syndrome, which
John,
would always be right.
The guy with the teenager, who says had some acute drug, intoxication versus delirium. I mean, are you going to get a delirium with a bunch of, if someone spiked the punch? I mean, wouldn't that be more?
It would be more likely to be intoxication, and the delirium. We just fall back on that old concrete response. The delirium criteria is only offered if the A and C criteria are met. So sometimes an individual who's intoxicated would meet A and C criteria, and then they would have substance-induced delirium. But if they don't, it's intoxication. And then if you're not sure, there's this unspecified delirium. So in this case, you run down to the ER. You get someone in the East Wing. Clearly, they've got a confusional state. None of the labs are back. Maybe the vitals are a little sketchy. So you know it's a delirium, but you don't know what it's due to, because the deliria are all due to something. So in the DSM-5, there's not just delirium. You have to say what it's due to. Does that make sense? And that's DSM-5 delirium.
John, one of the real common delirium is, there's like 12 different labs, they're just a little off. And somebody's on, 200 medications, and you know that somewhere.
And they have a UTI.
And they have a UTI, right. So how would you code that?
If I could back up. I can't believe I can't back up with this.
It was the bottom one on your specific list.
Yeah.
Multifactorial.
Delirium due to multiple etiologies, it's called. And then you have to list each etiology. So you have to say ICD-10 code for hyponatremia, delirium due to hyponatremia. ICD code due to benzodiazepine, benzodiazepine use disorder, moderate, delirium due to substance-induced benzodiazepine.
Every charge I use is going to have 50 diagnoses.
Oh, a little further, John. Thank you. A little more. Right here. Go up, jump forward. So just make that list. See? List your cause, and then list the delirium that goes with that cause, the proper delirium. March down the list, code it up, and you're winning. Okay. So that's DSM-5 delirium. Any other questions there? Amnestic disorders are gone. Conclusion was they never really existed anyways. I diagnose like one every 7 years. So say goodbye. It's the last time you're ever going to see it. Just quickly run through some DSM-4. So the DSM-4 template was have a generic dementia criteria, and when it's met, based on the cause, call it a different dementia. So in the case of DSM-4, you had to have a recent memory problem. That was a hard stop. And then one other cognitive domain problem. That's sloppy, and a lot of dementias can begin sparing recent memory, and the DSM-5 work group knew that. So that's the issue with this slide. And then these were the DSM-4 dementias. And this got weird because you've got with, 0.11 is with behavioral disturbance, 0.10 is without, but that can only be applied to dementia of the Alzheimer type. Vascular dementia has no additional specifiers for with and without. You say it, but you don't code it. And vascular dementia used to come with delirium, delusions, depressed mood, and uncomplicated as modifiers for that, but not for dementia of the Alzheimer type. That was weird. And then the dementia due to, but they did not give very clear explanations for how you would differentiate. Then they had the mysterious substance-induced persisting dementia, and so on and so forth. Some of those might be more familiar than other things, but you can see that there's a lack of tidiness there. So now we get into the DSM-5. The word dementia is gone. It no longer exists in the DSM-5. These are neurocognitive disorders, and they're either major or mild, not minor. And I think the reason for the not minor may relate to this ANPA conference we went to. I was grousing that if somebody's brain isn't working right and you tell them they have a minor neurocognitive disorder, they might feel that was a little unempathic on your part. And I think they might have gone back and huddled up on that because they have major and mild. So you can see, if you can think back to the DSM-4 dementia criteria, you don't see a problem with recent memory, and then 4 other cognitive domains listed. You can see they've got much more sophisticated. They're talking about complex attention now. They're talking about learning. They're talking about perceptual motor functions, social cognition. They're acknowledging that an informant is a useful person, or that the clinician can make the call. They talk about instrumental and basic activities of daily living. So this is much more neuropsychiatric and I think accurate and clinically relevant. And so this is the new basic template. So if you meet this, and there's independence in everyday activities that is substantial, you have a major neurocognitive disorder. And this is mild neurocognitive disorder, which is essentially the same thing, but in a mild presentation, does not interfere with independence, but it's a problem that people note, like mild cognitive impairment, Ron Peterson's clinical condition. And mild neurocognitive disorder is always coded the same, regardless of etiology, so I put the code up there for mild. It's a little weird that major is F05 or FO something, and minor is a G31.84, but so be it.
So the reason for those, almost all of the DSM-5 psychiatric or mental illness things are going to be Fs. Gs are neurologic.
Okay. We'll see some more Fs and Gs, and that makes sense to me. Thank you. Okay, that slide landed in the wrong place. Huh. Wow. Okay. So then, they now get into what I think is clinically realistic, possible versus probable for Alzheimer's disease, frontotemporal lobar degeneration, possible or probable, Lewy body disease, vascular disease, traumatic brain injury, okay, substance, HIV, prion. These are all the listed neurocognitive disorders in the DSM, and if there's something not on the list, there it is. Name it. These are also the proper codes. For the majors are all F, and the minors are all G. Or if you have a major neurocognitive disorder due to possible Alzheimer's disease, it's coded with a G, even though it's major. So the only example where major neurocognitive disorders get a G code is if the etiology is possible but not probable. And we'll have criteria for that. They actually give criteria now. They don't leave it up to your imagination. So we'll march through. Behavioral disturbance now applies to all of them. And now we have severities that are fairly easy to apply. Severe is somebody who's fully dependent. You can argue, does that mean they require assistance with all their activities of daily living, or they live in a nursing home? Moderate, difficulties with basic ADLs, that's like bathing, eating, toileting. And mild is difficulties with instrumental ADLs, which is like using the telephone, paying your bills, putting a menu together. So this is now the DSM-5 Alzheimer's disease. So they've given criteria for probable Alzheimer's and possible. And this is different from the NINCDS ADRDA criteria of possible, probable, definite Alzheimer's disease. Those criteria are actually kind of vague. So this is a new development. This is this is more specific than they've been before. And the DSM-4 criteria were previously kind of like the standard accepted criteria for clinical dementia of the Alzheimer type. Now they're actually getting into not the syndrome that is dementia of the Alzheimer type. They're getting into the disease itself. Because dementia of the Alzheimer type isn't necessarily caused by Alzheimer's disease. Then that confuses a lot of people and clinicians. So this is much cleaner. And then for the mild neurocognitive disorder, you can still say probable and possible but the criteria for probable and possible are different when it's mild cognitive impairment or mild neurocognitive disorder. And mild neurocognitive disorder is always G-coded. Right, Sandy? You know that. You're diagnosing dementia all the time. So frontotemporal dementia. Now they're acknowledging that it exists. The DSM-4 did not. It was dementia NOS. And they're actually giving us the behavioral variant and the language variant, and they're giving us criteria. So we can get much more clinical about frontotemporal dementia. So you can have a major neurocognitive disorder or a minor or a mild neurocognitive disorder due to this, with or without behavioral disturbance, mild, moderate, severe. These used to be called the progressive aphasias. So this group has killed off progressive aphasia, like primary progressive aphasia, progressive non-fluent, progressive fluent, and they're calling it frontotemporal dementia language variant. So that's kind of neat. And they've acknowledged, you can get either really active and disinhibited or you can get really inert. But they're now giving criteria so that clinicians can agree, and there's much less inter-rater reliability problems. Lewy bodies, I put in blue where the meat is. You can do, now we have probable and possible Lewy body. We never had that before. This is new. The McKeith criteria were kind of the original ones from the 90s. You either met them or you didn't. I think it's a great idea to have probable or possible, and that's how they do it. What I don't like about this, I will be honest with you, 2 core features, meaning that you could not have Parkinsonism and you could still be diagnosed with probable dementia with Lewy bodies. I actually don't agree with that. I think DLB patients are really Parkinsonian. I would be reluctant to diagnose this in the absence of Parkinsonism. And we know on P6 that when you take somebody with any dementia, leave them in their trailer with no one visiting them, they hallucinate in the trailer. They're understimulated, and they're kind of at the mercy of their imagination, and they get kind of psychotic. And then they come to P6, and you never see it because of the structure and the stimulation. So, but that's it is in these pots. Vascular. This is much cleaner. The old vascular, basically, I think as you guys knew, anybody that had dementia of any kind, whoever had a stroke at any point in their life was often getting called vascular dementia. The stroke could be completely removed from the part of the brain that wasn't working. It never mattered. So they're looking for much more discipline with this. Okay, and the temporal relationship is good. They never said temporally related before. And then it's probable or possible. So if you got cerebrovascular disease, but you can't quite line it up temporally to the problems, or if the lesions on the neuroimaging are just not frontal and the patient's very dysexecutive, you'd be able to put in possible. Okay, fair enough. It's all in the book, so this is just a quick orientation. Traumatic brain injury is now here, and they've given some criteria for what constitutes a traumatic brain injury. And again, they've put the timing of the neurocognitive disorder around the injury. In the past, they didn't. So you could actually, if these things were unrelated in time, you could still call it that. And they don't do that anymore. And then this is another one of those cases where you've got a medical cause of a neurocognitive disorder. And you can see here, just to give you a hint, the medical causes of, there's a lot of different codes for different kinds of TBI.
Is this where the football players will be?
Yes, they would. You could say that they, at minimum, have minor neurocognitive disorder due to possible traumatic brain injury or probable. We're getting kind of out into the hinterlands there for the people who Well, these football players are often disoriented, and you get one or more of the following. So yeah, like a high school kid who quote unquote gets his bell rung, as I used to joke about in the old days, has traumatic brain injury. Okay.
I'm thinking more of the older, the veterans who are my age and had lots of recurrent.
That would be a tough one, just because putting the temporal relationship together. And then we also know that people who have traumatic brain injuries are at a higher risk for having Alzheimer's disease later in life. So, but you can see we're out in the hinterlands of neuroscience right now. We've kind of pushed it as far as we can go with it with our current knowledge with this.
So is this where dementia pugilistica would not be, or?
Well, that's the football players.
Right.
This is you see the criteria there. Any blow to the head that is, but it's got to be immediately after, okay? And the pugilistica, it seems like it evolves more slowly. So you might call that an unspecified or something, or possible TBI might be a way to describe that. Okay, substance medication induced. Same themes as for delirium. There's a large list of drugs. Each has its own code. There's a substance use problem or not behind this. You got to state that. Now, this, I've never, there's the least amount of clinical pathologic correlation with your drug causing brain damage that leads to dementia, or what we call now neurocognitive. I've always had some skepticism for this. In my thinking, these are people with bad brains and unhealthy habits who have plaques and tangles in their head, and then they add substances and they bang their heads periodically, and it just brings out like a preclinical Alzheimer's disease. That's sort of how I look at it. We don't really have research that drinking a huge amount of coffee brandy causes plaque deposition in the brain and so on and so forth. But it exists, and if you are really confident that that drug is causing it and the temporal courses are lined up, you can diagnose this.
Well, Korsakov's dementia would fit in.
Korsakov's fits, and they've actually given you Korsakov's. So these are actually the subtypes of the substance use disorder, of the substance-induced neurocognitive disorders. So these are the different kinds. And you can see they've broken out alcohol into two different kinds. So if you think the alcohol did it, or certainly if they've got a Korsakov's, you got yourself a alcohol-induced major neurocognitive disorder. And then you can specify whether it's persistent or not. That's the only specifier. So, more detail, more structure than before. HIV, got to have a documented infection with HIV. And I think it's a good reminder that, hey, there's other complications of HIV that can also cause this. So I thought it was nice that they actually used stuff like this in the DSM, where they never did. If it was spelt too long, they wouldn't put it in there. Prion disease. These are the criteria for major or minor neurocognitive disorder due to possible or probable prion disease. Parkinson's disease. Parkinson's comes with a probable and possible, and they've given criteria for probable and possible, so I've just put them here to show you.
So prion disease is not subdivided into Jakob-Creutzfeldt versus others?
They're just calling it prion now. Yeah, it's interesting. And this group had some neurologists of high regard on it, so they keep changing their, like Pick's disease isn't on here, and then they wanted to call it Pick complex, and then they wanted to call everything that was frontal was Pick's, and then it wasn't, and Then it was frontal lobe dementia, then frontotemporal dementia, then frontotemporal lobar degeneration. So they're always kind of, and it used to be EPS, and now it's Parkinsonism with a lowercase p, and so on and so forth. Huntington's. Another medical condition, if you think, free to do it. It gets a little sketchy here. How do you know? You know, kind of in that article there, I said, you know, it insists on such certainty when we don't actually have scientific certainty.
Well, it's some like MS, though, where you would have a fair degree of
Yes,
guilt by association.
I agree, and MS is a great example. Okay, so that's the DSM part. Now let's go to evidence-based treatment, and in this case I picked aggression and psychosis in dementia. There is a high-level Cochrane meta-analysis for this, so I thought I'd present that. So the reason that the most recent update is 2006 is that because of the black box warning, it kind of put the kibosh on money and zeal going into researching atypicals. There are no FDA indications for anything related to dementia-related behavioral problems. So on P6, you're unencumbered by the FDA. How about that? So there were 16 placebo-controlled trials. 9 were worthy of a Cochrane meta-analysis, and a third of those were not published in a peer-reviewed journal. And that's the best available evidence. Here's the bottom line. As far as evidence-based treatment goes, for aggression, risperidone and olanzapine, and for psychosis, risperidone and olanzapine. I'll show you the studies that have been done. I think I put them in here. Well, okay. Not a free ride. So you start the drug, and you're going to trade target symptom for side effect, and then you've just got to decide if it's a good trade-off. It's always a good trade-off on P6 because you're stuck on P6, and nobody's happy with that. And as you push the doses, the tolerance problem led to dropouts in the studies. So 2 published risperidone trials, both positive studies. 2 published olanzapine trials. 1 positive and 1 negative, but the secondary analysis of the data was positive for psychosis, specifically for delusions. 1 quetiapine trial, negative trial. Patients actually did worse than placebo, and the authors recommended, from an evidence-based perspective, that quetiapine not be used. Quetiapine's used all the time, lots of places, and you know, this is, I think, the first evidence-based discussion. And you know, when you think about evidence-based, it's, you know, you got to decide whether you're on board with it or not, and what does it mean? Am I helping people with quetiapine? I think we've all had cases where you put them on the quetiapine and it's like great, and then you take them off it and they do worse, and then you put them back on, they do well. That's probably a successful case. But there's about a 30% placebo response rate in these studies, so if you do any drug at all, there's a 1 in 3 chance it's going to be helpful. So I think that's where the evidence might help out. Aripiprazole, 1 published trial, negative. Nothing for ziprasidone, nothing for clozapine. Okay, the risks, the black box warning. Schneider was the first investigator to identify this. He took the pharma data and he looked at deaths in the treatment groups and the placebo groups, and he found that your odds ratio for dying was higher on the active drug than on the placebo. That's the odds ratio right there. He then looked at Haldol because there were a couple hundred patients who got Haldol, and he actually found, you know, a slightly higher odds ratio, just in case everybody wants to jump back to the conventional antipsychotic. not a safer alternative. A couple of epidemiologists then looked at this in a more general sense with huge numbers of patients. This study had like 40,000 patients in it over a 10-year period. And it compared your risk of dying on a conventional antipsychotic versus an atypical. And across the board, the conventional antipsychotics conferred a higher mortality rate than the atypicals. Schneeweiss replicated this in British Columbia, looked at 90,000 patients, and found the same thing. This is an interesting study. Heibrechts looked at other classes of psych drugs in a nursing home cohort in Canada. So this is the only data I could find for SSRIs, benzodiazepines regarding mortality. And what he did in this study was he compared the other drug to the atypical. So he found conventional, we've seen this already. Then he looked at anyone on any antidepressant from any class. And then he looked at benzodiazepines. So interestingly, there's evidence that all of the drugs that we give old people increase their likelihood of death, and that the relatively safest is the atypical, interestingly.
Any differentiation on the etiology of the dementia in regards to that? I would think it'd be more complicated to use risperidol and Parkinson's dementia, for example.
The ability to know what the disease is inside their head is guess. And the criteria for dementia used in the studies is very noisy. So you can assume any study done for Alzheimer's, sometimes they'll just say Alzheimer's disease, but it's not definite. And some of the studies had possible Alzheimer's disease. So I think the bottom line is that this is a mixed population. They didn't analyze whether the presence or absence of Parkinsonian symptoms led to different outcomes and things like that.
Can we go back to the last slide for a second?
Yeah, Dr. Morris can dial it back.
So it's interesting that antidepressants fare poorly compared to atypicals, but I haven't seen any evidence saying that antidepressants have an elevated risk of mortality and morbidity in the elderly, not in the same way that you see the data about atypical antipsychotics.
Yeah,
Right.
there is an emerging literature on like SSRIs and increased fall risk about the same as benzos.
And is this for any diagnosis in the elderly, or is this just dementia?
This was I'd say this cohort was like 150 residents. Started for any reason. The thing they all had in common is that they were admitted to the nursing home in Canada and got placed on a psychotropic drug.
Okay.
And this is all-cause mortality. Really,
Yes.
you know, it's a pretty dirty
Yes.
sample.
It is.
All
It
counts.
is. You know, when you go trawling for the evidence, you never know what you're going to come up with in your net. But got to do something for our folks, and you know, risk-benefit analysis. This is.
John, the Katie investigators had a special paper just on Alzheimer's disease where they looked at atypicals, which I think was published after the 06, and their conclusion was it basically didn't confer benefit, but increased risk. Do you remember that? The Alzheimer Katie study.
For like risperidone.
So that conflicts with the Cochrane review. The Cochrane review did recommend.
I think it was published
So.
after the 06 review.
Yeah. I think by the time you're done with the evidence here, you're either never going to want to treat one of these patients or you're just going to try to do the best you can. But, you know,
We're damned either way.
Well, that's right.
damned either way. You know, arguably the fact that P6 isn't filled with the original 20 patients it admitted 10 years ago, I think is a good sign. Thank God, right?
But I wonder how they do that antidepressant versus atypical, because so many people are on both, and I don't know. Just wonder how they did that.
I put the name of the, I will email, I should have had the handout. I will email that because I have the name of the study and where you can find it. You can look at it in more detail. I read it once or twice a year, but had enough trouble trying to figure out DSM-5 for this talk, right? So Depakote. Depakote has a Cochrane review. There are 5 well-conducted randomized trials looking at Depakote for dementia-related agitation and aggression. And for time purposes, I'm just going to cut to the chase. It was problematic. And the opinion of the reviewers was that Depakote cannot be recommended for the management of agitation and dementia. This led to great lamenting on my part. Neuropsychiatrists love Depakote. And I actually stopped using it. And I will tell you, my average length of stay on P6 did not go up. So, evidence-based opinion on Depakote. Antidepressant research, there was nothing about mortality in this study, but it was found that sertraline and citalopram had positive studies. These were the 5, SSRI versus placebo. Some of them had other drugs included, perfenazine, Haldol, and so on and so forth. But looking at fluvoxamine, you can see, but citalopram and sertraline. And they were better tolerated in general, it appears, when you compare them to the alternatives. So, final evidence-based recommendations. First of all, try to avoid the med. There's plenty of other reasons why people get agitated when they have dementia. But if you can't, when it comes to severe agitation or psychosis, the best available evidence is for atypical antipsychotics when non-pharmacologic interventions fail, or when, patient gets to P6 because they're causing trouble at their nursing home.
What about cholinesterase inhibitors and Lamenda?
The studies with those drugs the pivotal trials have usually included a behavioral measure, like a Jeffrey Cummings instrument. What is it? It's the neurobehavioral something. They've all shown better behavior on the drug, but it's not as robust as this. And these are not patients who were identified as having problematic behaviors. But when you look at their behavioral rating scales, the subjects on those 2 drugs do better, behave better in general than the placebo group does.
Right.
I went through in the late 90s, based on that information, I'm like, I can fix it all with Aricept. That's great. And I just put them all on Aricept. And 2 weeks later, the nursing home nurses were just unhappy with me, and it wasn't working. So we went back to the evidence-based treatments, and they definitely work better. These were the dosage ranges for risperidone and olanzapine in the trials. The response to risperidone improved as dose went up. The dropout rate rose as dose went up. So risperidone dosing is eventually limited by tolerance, but not by lack of clinical effect for the target symptoms. Olanzapine, strange. Your best chance of this drug working is with 5 milligrams. 10 milligrams was more effective than placebo, but not to the same level as 5 milligrams, and 15 milligrams was not different from placebo. So that's where it was 5 to 10 milligrams, and strictly looking at the evidence, your best shot is with 5. Don't leave them on the drug if it isn't working. And if you don't want them on the drug, the evidence suggests you should wait until at least 12 weeks. And that was based on one published risperidone trial that had a very large N, I think like 600 subjects, that by week 12, there was no longer a statistical difference between the treatment group and the placebo group. And it was because, not because the treatment group deteriorated, the placebo group improved. So at minimum, the nursing homes have to do gradual dose reductions twice a year, and I just recommend wait at least 12 weeks and then try it. We've talked about the conventional the other risks for the other drugs. That was a small study. I think it's just worth keeping in mind that there's no entirely safe haven for pharmacology for dementia-related behavioral disturbances. And when the black box warning came out, I saw a lot of primary care doctors' practices evolve into jumping out of that class into these other classes that they were comfortable using. And it's just a reminder not to be entirely that they're not that necessarily safer. Cochrane reviewed Dings, Depakote, and those were the dose ranges for sertraline and citalopram. I use sertraline. I find it to be very helpful. Sweetens people up within a couple of days. And I used to keep a lot of Detroiters out of the nursing home and at home with their families with sertraline. All right.
Different population than, say, Portlanders or Cape Elizabethers.
It's culturally different. They don't want to put their parents in a nursing home like we do. That's like a sign your family is a bad family. It's very interesting. So that's DSM-5, delirium, neurocognitive disorders, and that's evidence-based treatment of dementia-related agitation. I hope this was good. I guess it shows we can get it in under an hour if we try. And yeah, thanks everybody.